Hello, welcome to September 2020's CCU Enrichment, which is Target Temperature Management, Rehearsing the Clinical Practice Guidelines. So welcome to this. The goal of this presentation is to show you where to find the resources needed to administer TTM correctly and give you a way to organize your thoughts about the tasks during the TTM process. So first, let me show you some things. We're talking about the TTM CPG, and where does that live? Well, let me show you. First, we go to the intranet, and I have this up. Here we go, intranet. And you can go to Pen Pathways a couple ways. There's a little button here. There's also a button over here for Pen Pathways. It's going to open up. And also called Dorsata. There's a lot of pathways here. If you're not used to going into this, I recommend getting used to doing it. I'm going to type TTM, and that's going to bring me to the post cardiac arrest target temperature management, which is right here. And this is a 13-page document that is our clinical practice guideline around TTM. And there's a lot of information in here. It's great. It may be a little cumbersome to try to figure out in the heat of the moment if you are trying to initiate TTM and you're not really comfortable with what is inside this document, but that's what this enrichment's for. The other way you can get to this pathway is going through the formulary. Let me come back out to the intranet here. More. Okay. You go to the Pen formulary, you type in post-arrest TTM, and it will give you that same document. It's not formatted as big. It's a little bit, it's like they took a picture of it, so it's smaller. So if you want to print it out, I recommend going to the pathway. The other place I want to talk to you about is going into your nursing policies and show you that, because that's really what we're talking about. We're talking about the CPG and the nursing policies. And in HUP nursing policy, I'm going to go categorical, cardiovascular, and know that there's a fairly recent post-cardiac arrest target temperature management nursing care policy. It's right here, 3 pages long. Kind of tells you what you're supposed to be doing when and when to document. Okay, so those are things are there. Now, we're not really going to talk about research here or the pathophysiology behind TTM. This is more of a task-based, what do you need to do to rehearse the presentation of doing this well. But I highly encourage you to get some education that way. And one great way to do it is through the TTM Academy through Penn Medicine. You can just Google TTM Academy. And they've got a lot of good stuff here. Let's see, it's going to go through here. There is a virtual... let's go here. There's a virtual TTM. Oh no. Went the wrong way. Anyway, we know that, yes, here's that guy. Virtual live 1-day course, October 16th from 9 to 3. And that's going to be exciting. I think it's about $65 for nursing. You can pay for it out of pocket and then get reimbursed through your professional development dollars for the year. Ask your manager how to do that. If you can't do that, they also have some other asynchronous learning things. There's an online module that you can take, which is about the same price, and you can get reimbursed for that too. There are podcasts, and I downloaded the podcasts. There's about 20 right now. And there's some really interesting information in there. You don't get any CEs there. I think for the online CE, the asynchronous one, you get 3.5 hours. But there's a lot of great information there if you want to talk about the pathophysiology and the research to the basis. And Dr. Abella, who I believe, yeah, it's Dr. Abella. If you don't know him, he's an attending from the ER and runs a lot of the TTM policies and tends to answer the TTM resuscitation phone if you need to call him for advice. And he's really a great speaker and does a great job making clear what it is you need to know. So highly recommend pursuing those educational opportunities outside of this enrichment. Okay, get my speaker's notes off here. So those are the resources I want to talk about. The other thing I want to mention is that there is that 13-page CPG. There is a TTM nursing tip sheet that kind of has all the kind of things you need to make sure you're hitting at the times. It may be added to that CPG soon. If not, or if you need it in the interim, you can get it out of our shared drive, which is the G drive. So you go into the folder on the computer, go to the G drive for CCU shared drive, go to the practice folder, then go to TTM within the practice folder, and this one is listed Final Nursing TTM Checklist. So kind of make sure that you're getting what you need as you go through. But we're going to talk about that in a little more detail so the text makes sense. So before we go further, bottom line is time is brain. The whole point of targeted temperature management is that we are trying to slow and decrease any sort of damage that can happen to the brain once we have reperfusion injury from cardiac arrest. There's a lot of things that go on cellularly, and we have found that keeping the brain at a lower temperature, not letting it get into a fever, and keeping it there for a while can help produce better neurological recovery. And that's really our end goal, what we're trying to do, is get the best cognitive status for that patient after cardiac arrest, should they survive. So we really want to act quickly and adequately and accurately through this TTM pathway. And I will say that all patients, and this is what it says in the pathway, and there's research that we're not going to talk about the research, but in the pathway, who should be considered for targeted temperature management? And the answer is everybody. Anybody who is arrested in any location with any sort of rhythm should be evaluated for TTM. Now, who should be included and who should be excluded? Well, if you are comatose after getting back ROSC, so you get your ROSC and they're not following commands, it doesn't mean that they can't withdraw from pain or have a cough or a gag, but if they're not following commands for you, you should include them into the bucket of people that are going to get TTM. Now, who should you exclude? Well, if they have a Glasgow Coma scale of 6 or above and they can follow commands for you, and one of the things we always say is, can you give me a thumbs up? Because that's actually complicated. And if the patient can give you a thumbs up, then we know that they're kind of okay, and we don't need to do TTM. But if they're just withdrawing from pain, or there's a gag with suctioning, whatever, that's probably comatose, and they should be in the bucket of yes. Now, if they have poor baseline cognitive status, maybe TTM isn't going to make anything better, and that's not the best way to go. Also, if they can't keep their ROSC, they keep having non-perfusing rhythms, and they're in bad shock, and you really don't have them stable enough to TTM, then maybe you can't TTM. Also, if they're DNR and they don't want to do this, the family thinks this is not in line with what they would have wanted, then you don't do TTM. But if you look like you are yes for TTM, then we have some decisions to make. Are we going to head CT? And the answer is generally yes, especially if it's an out-of-hospital arrest, because you're looking to see if they fell, if there's trauma, and it's really, as Dr. Abella says, binary for blood. Is there blood in there or not? And if there's blood in there, then we have to manage you differently than if there's not blood in there. It's not really any sort of neuroprognostication of what's going to happen with you, but we're looking for blood. Also, is this a STEMI or is this an NSTEMI, or is this something that could benefit from coronary revascularization, and should the cath lab be activated? So that's something that needs to be thought about. And know that you can cool while you're getting cathed. So think about that too. If you are the nurse that's in the CCU, are they cooling in that cath lab? Or do they cool in the ED? Are they cooling from wherever they arrested? Do they need your help to get that stuff going? Do you need to get that stuff going? Because we're on a time crunch here. You also need to know what is the target temperature? Where are we going to? Are we going to go to 33 degrees, or are we going to go to 36? And we'll talk about that a little bit too. I think the thing I really want to impact on you guys now is the shivering plan. Once we're thinking about whether they're going to the cath lab, whether they got their head CT, what the target temperature is, what shivering plan are we using? And you need to ask the provider this. Are we going prophylactic? Are we going reactive? Because that's going to guide how we treat them as we are getting them initiated for TTM. Shivering plan, prophylactic versus reactive. And know that there is a ton of things that we are doing at once. We need to prioritize and organize these simultaneous tasks. And on that note, I'm trying to make the acronym CSLOP happen. I don't know if it will take, but thinking about managing those multiple priorities within that initiation phase. We are thinking about cooling. We're thinking about shivering or sedation. We're thinking about our labs, our lines, our lights. We're thinking about the other studies that have to happen while we're initiating. And this isn't actually in the pathway, but I thought I'd throw it in there so I can make the word CSLOP. Patient family support. Once we're doing all these other things, is the patient's family in the waiting room? What do we need to communicate to them? How can we simply support them and communicate them so they understand what we're doing? Let me see if I can make CSLOP happen as a way to think about how we're managing that big kind of onslaught. And if you've been in TTM, you know that there's like all these things that are happening at once, and there's a fear of missing things. So maybe this is a better way to assign what's happening. So let's start with the C, cooling equipment. Oh, no, hold on. The thing I want to say is that the pathway also says that we want to cool as soon as possible, but ideally within 4 hours from that arrest. We want to get to that target temperature. You want to get to the target temperature down to 33 degrees or 36 degrees within 4 hours from that arrest. So that means we really have to get going because they got to cool down. Once we get past 12 hours post-arrest, then we're getting that neurological problems. We're getting that cascade of reperfusion injury and mitochondrial dysfunction. So we really want to try to get ourselves to that patient down to target temp within 4 hours. Okay, and that's why I'm thinking maybe it's good to have a little bit of an organized pathway of how to do things. In terms of thinking about temperature, this has gone back and forth over the years, but the pathway says 33 degrees is where we should really be aiming, unless we have some sort of issue with bleeding or underlying condition that makes us think that 36 is the better choice. But you should be preferentially cooling everybody to 33 unless you have a really good reason to make them 36. Now, if they show up and they're very cold, like less than 30 degrees, which is 86 degrees Fahrenheit, know that you could be in danger for cardiac arrhythmias, VFib, etc. So we need to warm them back up. And the machine will warm them if you have them on the wraps. But know that that is kind of a danger area. And so you don't want to overshoot keeping them cool, especially if you were giving chilled saline and all those kinds of things. So 33 degrees, generally where you're going to go, unless you got a good reason to go to 36. So let's talk about the C and the C slop that I'm trying to make an acronym for your planning. So cooling equipment. We need a temp probe Foley, and that's generally what we're going to use. And the bar, you don't need to make urine in order to benefit from getting the temperature on a temp probe Foley. You do need to make sure that it's happening here, and make sure that sometimes people don't know what you're talking about. It's the one that has the little thermometer on it. That is a temp probe Foley. So before you rip it open, make sure it's the right one. Cooling equipment. So we use Arctic Sun, and we have several consoles throughout the hospital. Now, sometimes people forget this, but we want to use the same console for the whole case because that console is recording what we're doing, and then they can see the whole case and download it. So if somebody comes from the MICU or the ER with the Arctic Sun already in place and they're reluctant to give it to you, tell them, we really do need it for the whole case, and we're willing to give you our console to trade until this patient is off TTM. So I've gotten people with wraps without the console, and I've had to run up and try to get it out of the unit, that console, so that we can continue with the same console. So encourage the sharing of consoles, and usually we have enough. So same console for the whole case. When you need to transport somebody, that's where people get anxious. So there's a way to transport. You empty the pads. You put the water back into the reservoir from the cooling place. Empty the pads before transport, then disconnect, roll your console up to the new place you're going to be, reconnect your pads, and then restart. Resume the therapy. Okay? Don't just disconnect them without emptying the pads because water is going to be everywhere. We've had that. And just make sure that you're trying to keep the same console. The wraps, we used to have to stock ourselves, but know that CDR does have the wraps in stock. So you can order them. Sometimes we'll have some in the back already ready to go, but try to make sure that you're getting the right size, small, medium, large, or you could use a universal pad. Those universal pads go well over the belly. You can use up to 2, and they will, if you found, especially if you're having trouble getting them to target temperature, think about whether or not you're getting enough surface area, and you may need to add a universal pad. Now pick wisely, don't rip up everything. These pads are expensive, so try to figure out which pads you need before you open them up. You can always return unopened pads. And make sure that you're subtracting the weight of the filled pads when you're getting the daily weight. And there is a card that has that information on there. Okay, cooling documentation. This is where we always kind of forget. Not really forget, but it's like, where is this? Under assessment in integumentary, you see there is the bath temperature that goes right here, right? So assessment tab, integumentary, add the bath temperature and the set temperature. We want the warming method, and we want the bath temperature in degrees Celsius for documentation going forward. Cooling equipment. So if you're still having trouble getting that patient to target temperature, you can do some cool saline, which you may have in the med fridge. Don't overshoot. And also, some people won't tolerate that, especially if they have ARDS or sepsis or, well, maybe not sepsis, but ARDS for sure, and some other problems. So cool saline used to be part of what you got no matter what, and now it's like if you need it. So just know that it's an option if it's possible for you. Now, this is what I really want to talk about, is your shivering plan. Ask them, are we going prophylactic or reactive, and what does that mean? So now, prophylactic shivering plan is our, old school way of doing TTM for those of us have doing it for a while. You give somebody a sedative, some analgesia, you give them, make sure they're comfortable, then you bolus them with a paralytic, like mostly cisatracurium. You got a baseline train of 4 ahead of time, you got the BIS machine there, and you're basically paralyzing them through the rewarming. And you're knocking them out and you're making sure they're not moving so they don't shiver. So the pro of this, the best thing about using neuromuscular blocking agents and sedatives all through TTM is that shivering variable is gone. They're not moving. And we're not going to mistake shivering from myoclonic jerking or seizing or whatever. We have knocked them out. So we have that variable gone. The problem with that, of course, is now that we have the risk of heavy sedation or more sedation, and that can mask their neuro recovery and increase their delirium risks down the road, and all the problems that, the risks of administering paralytics are there. The reactive plan, which is a stepwise plan, really advocates for less sedatives and no paralysis at the onset. The con of this is that we have to be really good at it. And I think that's where our opportunity lies, is getting really good at knowing how to run that reactive shivering plan pathway and that stepwise thing. Because unmanaged shivering can worsen the hypoxic ischemic brain injury. So we don't want to mess this up. We want to do this well. So let's talk about that a little bit. Prophylactic shivering plan. Talk about this. You get a baseline train of 4. You get the train of 4 out, and then you give a little fentanyl. Maybe you give a little propofol or benzo, but you have to have both fentanyl and either propofol or Versed, something running together during paralysis. You get your cisatracurium bolus, and then you run a continuous drip. So you make sure you sedate them first. Then you paralyze them. You get the BIS on there because we like BIS here in the CCU. We make sure our BIS goes between 40 and 60 because that monitors the sedatives. And we stop it all when we get to 36.5. So that's what we do. Now that we're familiar with that, hot tips on that: do your baseline train of 4 prior to giving the paralytics. And the MA that you get, the energy that you get for the train of 4 is the energy you use for the whole case. Also remember, the BIS picks up skeletal muscle, so don't start using that until you've actually paralyzed the patient. And don't get too caught up on getting that train of 4 monitoring. Hypothermia can result in unreliable settings going forward, so just keep those clinical goals in mind. Here's a picture of the train of 4. Placing it always kind of is a little bit of an issue, so I'm trying to make the other thing to think about is, they used to say red and black, and then they took those pictures out, but we're really looking at the landmarks being the tragus and the outer canthus of the eye, those two things. So I'm going to say neg to treg. The black or the negative one should be at the tragus, the line of that little part of the ear that kind of comes out closest to your nose. And then the outer canthus of the eye, and you want to line those 2 electrodes up, and then you're going to stimulate those using the train of 4 button, and you're looking for that eyebrow to raise, or that nerve to raise there. So you keep increasing the MA and stimulating it, and when you see 4 twitches that are good, you can say, I've got a baseline train of 4 out of 4 out of 30 MA or 40 MA or whatever it is. But that's what you start with. You don't then try to increase the MA later on in the case. All right, so that's train of 4. This is the table about the recommended boluses and starting infusion dates if you chose to go for the prophylactic shivering plan. Here's a picture of our BIS monitor. I've circled where the EMG is. So that detects electromyography, that can detect the artifact. So if you may have an artificially elevated BIS value if there is muscle activity going on because the patient's not adequately paralyzed. So determine whether or not you have artifact before you start increasing your paralysis rate or increasing your sedation rate. Now, reactive shivering plan. So this is where we have to really be thoughtful. We're treating pain and agitation all the time using our behavioral pain scale and our RASS. We're assessing for shivering using the BSAS, the bedside shivering assessment scale. And here's the things we're doing. We're performing counterwarming interventions on everybody. So we're making sure we get our good surface counterwarming going, and then we're going to do a stepwise pharmacologic approach, and it's progressive. Assuming that there's no contraindications, we're going to give Tylenol around the clock. We're going to give Boost Bar around the clock. We might want to consider, and this is new for people, and a little bit of surprise, keeping that MAG level. Increased MAG levels can help decrease shivering. Keep that level between 3 and 4. If we're still not getting what we need, we can give some boluses of fentanyl or meperidine. We could start with a benzo bolus or maybe do a propofol infusion. If that's not working, then we can do a benzo drip or a fentanyl drip and then do paralysis boluses. If that's not working, then we can do, just like we started with the prophylactic plan, and be doing neuromuscular blocker continuous infusion with those continuous infusion analgesics and sedation drips. But there's a lot of steps before we get to that. So just make sure we're trying to do them well. Let's talk about the bedside shivering assessment scale, because that's also a little bit new to us. Now, the bedside shivering assessment scale requires raters to observe the patient for 2 minutes. And this includes looking at the inspection as well as palpating the neck, the thorax, the arms, and the legs. And 0 is no shivering. And 1, and that goes 1, 2, and 3. We are required to document the BSAS every 30 minutes during the initiation until we get to target temperature. And then we do every hour until they're warm. Okay? Now, I struggle a lot with finding where that BSAS is. So here's a tip. Go to Add Rows, either in the Vital Signs flow sheet or the ICU flow sheet, and type in bedside or BSA and BSAS, start that, and it's going to give you that HUP EPSS, bedside shivering assessment score thing, and add that to your row. And that's just the easiest way to do it. Surface counterwarming, what is that? Okay, so think about this for everybody, that you're not paralyzing at the get-go, all right? You're going to get a warm blanket and plop it on the head. You're going to maybe take some warm packs and maybe put them in with some socks on the hands. You're going to put socks on the feet. You're going to put that bear hugger on top of the Arctic sun cooling wraps. That is surface counterwarming. This is tricking the body into thinking it is warmer than it actually is, like holding a hot cup of coffee. And we should be doing this for everybody that we are not paralyzing at the onset. Okay, we should be doing that for everybody we are not paralyzing at the onset. Good surface counter warming. All right, this is the shivering pathway multi-pronged treatment. That is table 4, page 7 of that CPG. And you see it's a little bit busy because there's a lot of things within those steps. But I'll show you step 0, which I guess means that we're on the floor. And that means we should be initiating the standard nursing preventative measures of induction of TTM, which is the BSAS Q30 minutes, so we're looking for shivering. And then we're also looking for surface counterwarming measures. Socks, hands to feet, blanket, blanket. And then we're going to do Tylenol, Boost Bar, and possibly MAG. We might not, if they have liver injury, we might not use that, but maybe I could try to make CAB-M happen. Counterwarming, acetaminophen, Boost Bar, MAG. Everybody should be getting that to start with. And then if we are not getting success with that, then we should start thinking about adding fentanyl and the benzos and the paralytics, but not until we've really exhausted that step 0, okay? So that is something I think we really could work on getting really good at, knowing the verses on those, so we can perform that well. All right, so in our C-SLOP thing, we've done cooling, we've done our shivering sedation stuff. Now we're on to L, labs, lights, lines. A-line is a great plan for blood pressure monitoring and for getting ABGs in serial fashion. Central line's excellent for making sure we have our repletions and pressors ready to go. It's not going to get easier as they get colder, so try to advocate for lines early. We're doing a lot of labs initially, and then we're going to do some stuff serially, but we're going to do a drug screen probably, a pan culture. We're going to get a VBG for central co-oximetry. Maybe we have a SWAN. We're going to get an ABG. We're going to be looking at that lactate. We're going to be looking at that iCal. We're going to replete those things based on that. We're going to get panels. We're going to get cardiac enzymes. We're going to get LFTs, amylase lipase. If they're childbearing age, a pregnancy test, please. CBC and coags with a fibrinogen at the onset. All that good stuff goes in at the beginning. And then we're going to go to other studies. We're going to think about getting a chest x-ray. And maybe you want to put an OG tube in there, get your KUB, and make sure you got an order saying it's okay to use. EKG, we can control that. The EEG, we can't control so much, but know that we should be advocating going, oh, you know what, the EEG hasn't happened yet. So make sure that the EEG happens, that they order, that they call, they do whatever they need to do to put the EEG on. I think it's like 12 hours that they have from onset to get over there. So depending on the time of day. And then an echo. Now we're in the CCU. Nobody's going to be, we don't need to tell anybody to go get an echo. And then the P would be for patient, but it's not really in the pathway. Don't forget to document your phases. Just remember about the time stuff, and that's in the nursing policy. You want to document the time TTM is initiated, the time target temperature is reached, the time the rewarming starts, and the time normothermia is reached. Make sure you're documenting that somewhere in the notes or in the provider notified or something so that it's easy for us to see. Okay, so we have cooled them. Maintenance phase. So maintenance phase is a little bit of time for us to look back and make sure that we haven't missed anything, and we have some time. Maintenance phase, you're going to keep them at the target temperature for 24 hours is what the pathway says. Now there is this new study that is coming out. We may be asked to maintain that at different times. I think the arms are 12 hours, 24 hours, and 48 hours. So time of maintenance may be variable based on that study, but the pathway says 24 hours. Things to think about, both in the initiation phase, but there's not a lot of time to think there, but in maintenance, remember that there's possibility of hypothermia-induced diuresis. So you want to make sure that you're repleting those lights based on the pathway, PRN pathway that's already there. So think about that your K is going to, and your MAG may be shifting down, your ionized calcium may be shifting down to replete those. If the patient also needs CRRT, you're going to use CRRT as your repletion pathway. Okay. Know also that during hypothermia, there's reduced insulin secretion and sensitivity. So your glucose may start to rise during hypothermia. We want to have a goal glucose of 140 to 180. So we may need to start an insulin drip if that situation arises. Also know that pharmacology is different in hypothermia. So there's a tendency for bleeding. So heparin can be adjusted differently. That's on page 9 of the pathway. Just something for you to think about. That should be a written order. Ticagrelor is the preferred P2Y12 inhibitor. If you have somebody that just has a fresh stent post coming out of the cath lab for TTM, Plavix will not cut it for them. All right, and this is also a great time to think about all the other orders and stuff and make sure you didn't miss anything like that EEG or the EKG. We're also doing serial labs and chill warm. So every 6 hours, we're doing an ABG lactate ionized calcium every 6 minimum. We're also getting cardiac panel, troponins every 6 for 24 hours. We're getting panels every 6 hours, mag and phos every 6, CBC every 12, PTINR daily. Making sure we're documenting well. So hourly things that have to happen through initiation and through maintenance is vital signs. Doing that BSAS every hour once you get to your target temperature. Before that, it's every 30. Making sure you're documenting the bath water temp on that device. And that's when you added that early on because you're using Arctic Sun, and you're going to document the bath water temp in degrees Celsius. And what that really means is if you have somebody that's trying to mount a fever, the water in the machine is going to be cold because it's trying to cool that patient. If the machine's water temperature is actually on the warmer side because the patient's actually trying to drop their temperature because they're dying, it's good to know that too. So we want to see what the bath water temperature trend is, and you're going to document that every hour, and that is on the machine. Now, if you're doing train of 4 bis, if you've paralyzed this person, then you're going to wind up doing that hourly as well. Other things you're going to want to think about are neurochecks every 2 hours. Your BPS and your RAS scores are every 4 minimum, but if you have med titrations, you're increasing sedation, you're going to do that as ordered more frequently. Skin checks every 2 to 4 hours are important as well. Okay, 24 hours of that. Now we're into rewarming. Now don't let anybody start rewarming until you're actually ready to rewarm. You can make that maintenance phase a little bit longer, assuming you're not in the study, if you're not ready. So make sure you have all your head about you before you start rewarming. You want to rewarm slow. Now it's programmed in Arctic Sun to do it this way, but just know that you should not be it should not be rewarming the patient any faster than 0.33 cc's of degrees Celsius per hour. So a third of a degree Celsius per hour. So if you're going from 33 degrees to 37 degrees, that's going to take 12 hours. If you're only going from 36 to 37, it's going to take about 3 hours, 4 hours. Think about those things that we thought about earlier. Potassium shifts during the rewarming. So we were having hypothermia, diuresis. Now we're going to be seeing some serum increase in potassium. So do you see anything that's just running that has K in it prior to rewarming? And check your potassium 2 hours after the rewarming starts, all right, to make sure that your K is not elevating to a dangerous level. Your glucose shifts are going to happen too. If you remember, there was decreased insulin sensitivity in hypothermia. Now you're going to see that come back. So your glucose may drop. So check your glucose 30 minutes before rewarming starts, and then check hourly during rewarming to make sure you're keeping track on that, especially if they're on an insulin drip. Just follow your insulin protocols, but you may come off that insulin drip pretty quickly. Also, this isn't so much in the pathway, but anticipate vasodilation and make sure you have a pressor plan ready to go. And if you are paralyzing, do you see that paralytic once you get to 36.5 degrees Celsius? And also stop looking at your BIS at that point too, because once you stop paralyzing, you're getting that muscular activity on the forehead, and you're going to see an elevated BIS, and I don't even know why you're documenting it then, so take that off. Okay, normothermia, we're almost done. This is the period of time where we want to make sure we don't let the patient get into a fever. And we're going to say that's between 48 and 72 hours. We're going to try to keep that patient at 37 degrees. Keep those wraps on for about 48 hours. Now know that those pads are not good for more than 5 days. So if you were in the rewarming phase a little bit longer, the initiation phase took a little bit long, you can't leave those on forever. So take them off after 5 days, but keep the wraps on for 48 hours. Prevention of fever is important. We may be doing round-the-clock Tylenol, et cetera, et cetera. If you're still using sedation at that point, and you're still monitoring for shivering, which you probably should be, and if they are shivering, you can tolerate a little more shivering, like a BSAS of 1, if it means that you can come off the sedative. So don't sedate just to get to 0 shivering in that normothermia phase, because that's really just keeping us from getting to the point of being able to assess neurostatus if we keep staying on those sedatives. And no neuroprognostication until after 72 hours of being rewarmed. So we're going to have to, it's going to be a slow marathon of seeing what's happening. We're going to follow those pathways for delirium mitigation as we start to see mental status, and making sure we're following behavioral pain scale and agitation, and trying to do all those good things we do non-pharmacologically for delirium, because you may see a patient move from coma to delirium to actually having a cognitive status. Okay, so this is a 33-minute thing. Now, if you wouldn't mind, if you'd like an assessment, this is a post-lecture quiz. So take your phone, if you haven't done this, although I think we've done a lot of these lately, take the camera part of your smartphone and put it up to the QR code, and it should release a browser, which will take you to a Google form, which has a quiz. 5 questions. Once you submit it, I'll tell you the answers on it. The answers will show up on it afterwards. So I hope that this was a helpful guide to you about TTM enrichment. Of course, you know where to find me, so we can talk about it anytime. All right, thanks so much.